welcome to today's Scottish Drugs Forum webinar. I'm Dave Little, CEO of SDF, and I'll be chairing today's session, which will run until no later than 2:20. This is the first in a series of webinars focusing on the medication-assisted treatment standards from 1 to 10. The aim of the webinars is threefold: to continue to raise awareness of the standards, to highlight emerging good practice, and thirdly, to highlight challenges that remain with full implementation and how these may be addressed. Today, we will be focusing on MAT Standard 1. A link to the full standards is provided in the chat. There has been some excellent progress in implementing standards across Scotland to date, but as the Minister for Drug Policy, Angela Constance, outlined in her update to the Scottish Parliament in September, much work remains before we achieve full implementation. There has no doubt been frustration within government regarding the slow rate of progress to full implementation. This was highlighted by a ministerial direction being put in place. This means that there will be much closer oversight by government of moves to full implementation. As I have said, today we'll be focusing on MAT Standard 1. All people accessing services have the option to start MAT from the same day of presentation. We will start with some short inputs from people with living experience, which have been presented at previous SDF webinars. This will be followed by 3 presentations. Firstly, Trina Ritchie, Lead Clinician and Senior Medical Officer, Glasgow Alcohol and Drug Recovery Services. Shelley Jones, Advanced Nurse Practitioner, Community Addiction Services, West Lothian. And thirdly, Jamie Tidder, Consultant Psychiatrist, NHS Borders Addiction Services. The presentations will be followed by a question and answer session and panel discussion. You can submit questions throughout the webinar through a Q&A tab on your toolbar. My colleague Austin Smith will be monitoring questions as they come in and will join us for the Q&A and summarize the questions being asked. So let's get started, and we'll hear first from the living experience perspectives. Thank you.
From my own experience in addiction, you have a very small window of opportunity when you want to change your life. So if you go along to some sort of service for addiction and say it's a frontline service, like, you know, methadone prescribing or whatever, and you go there that day, you really want your life to change that day. It's got so bad that you want to change that day, you know what I mean? And to be told you'll need to come back in 3 weeks when you don't actually know where you're going to be in 3 weeks or how you're going to be in 3 weeks, if you're still going to be living in 3 weeks, because things might be so bad that you just need to desperately change your life that day. And from my own experience, sometimes when I've not been able to access that treatment, that service or whatever, it can take, you know, 6 years before I rotate back round to deciding I want to change my life again. I mean, I was a lucky one. Obviously, there's other people behind me and in front of me that never rotated back round, you know what I mean, who died out there and died as a result of they couldn't come back for 3 weeks. They couldn't come into a doctor's surgery and sit there, you know, and just keep up with them appointments or whatever for 3 weeks. So I think it's vital.
I think this is a brilliant thing. I think this should have been brought out about a good few years ago, when things were at a crisis. Well, it's even more at a crisis now.
Same day prescribing, you know. Aye, just as I say, the name says it all. You'd be expecting a script when you left that building that day, or want to be at your chemist, or no. That's what same day prescribing would mean to me.
I think it's imperative for people to realise, for workers to realise that when people go in that mindset that they want to change, that it's important to capture them there and then. And same day prescribing kind of mean same day prescribing. I think same day prescribing is crucial. Now, this waiting for months, when the interviews, some of the interviews that I done, you know, people were waiting months and they were actually grateful for being prescribed at the end of that, which was, it was beyond my comprehension that people actually felt. I think what's really important is these people are human beings. You know, they're not just addicts, they're human beings that deserve a chance.
Folk have been medicating, and when you turn up and you don't get that prescription in the same day or anything like that, and you're told, well, you maybe have to wait 2 or 3 weeks. 2 or 3 weeks is 2 or 3 hours in the life of an addict can be a lifetime, feel like a lifetime, never mind 2 or 3 weeks. The mindset can change hour to hour. So you really need to be getting the people straight away and saying, look, right, there's your prescription. That'll take care of your physical withdrawals and stuff just now. And we'll put a plan in place to deal with either mental health or physical issues later on in that. Because there's a lot of trauma and tragedy and addiction, and it would affect anybody. So we really need to be seeing that day and listen to and gain that voice that we want to get better, and that's all it is. We're turning up there, we're worse. We just really want to get better, and if we don't get it at that time, we might feel, oh, they think we're not worth it. So people will not just, some people just will not come back to the services because they've felt they're looked down on, they're embarrassed that they've let themselves get into this situation that nobody knows about, stuff like that. So it's really kind of pertinent that you get seen that day.
That was a really important contribution to kick things off. I'd now like to ask Trina Ritchie to present. Thanks, Trina.
Thanks very much to Dave and the Scottish Drugs Forum for inviting me to talk today about our experience in Glasgow Alcohol and Drug Recovery Services in implementing MAT Standard 1. I don't have slides today. I started writing some slides. I thought we might still be here tomorrow with me talking with everything that I thought I could squeeze onto them. So I'm just going to talk today. And I have spoken previously about some of the initial implementation work of MAT1 in Glasgow. So apologies to those of you who've had to listen to some of this before. Just for background in Glasgow, we're very lucky in that we're a fully integrated team, integrated health and social care. We're a really big service, so we have medical and non-medical prescribing staff in our staff bases across the city, and we've always managed our own front door, so we screen our own cases into care and treatment. So we're at pretty good background position in terms of getting people started in OST. When I was working in the sector teams, I was a bit concerned that despite that, there might be some practice and process barriers to starting people. And in 2016, I did an audit in a sector of the city that showed that it was an average took 34 days for somebody from when they first asked for treatment to start on OST. We looked at some practice and process, and 2 years later, that average became 14 days. That was in 2018, and early in 2020, before, around the time of beginning to develop the MAT standards, the average was 9 days from asking for treatment to treatment start. But during that time in Glasgow, even then, we were able to do some same-day starts. So for very high risk clinical situations, high risk neck injecting, or somebody who was needing OST treatment late in pregnancy, we were in a position occasionally to do same day OST starts, but certainly wasn't the norm. We had something to build on. So now I'm thinking we're more than a year after the publication of the MAT standards. Where are we now in Glasgow? And our latest figures that I can talk about are from March of this year. And that is really because we have to look retrospectively and do a manual audit of cases to follow people's journeys and to look at how implementation is going. And it's quite resource heavy. So we have more than 200 people who are referred in or refer themselves into the city on a monthly basis. And we have to go through all those cases and look and find who is opiate dependent and suitable potentially for OST. So in March of this year, there were 67 people who presented looking for treatment for opiate dependency, and 79% of those people started an OST with a median time to treatment of 1 day. 20 people started the same day, so that's 38% of people who started an OST were started on the same day, and 66% of people were started in treatment by day 3 of them asking for treatment. So what does that mean? Is it a success story? I think we should not really meant to come on here and blow your own trumpet, but I think, that's absolutely great. We're really demonstrating that there is choice to start OST on the same day that you ask for treatment. Then begin to think, how much of a success story is that? And what are the numbers really telling us? I always think we have to remember as well that MAT Standard 1 is about the choice and ability to start OST. So we're not aiming for 100%. And it's then very difficult to know what figure are you aiming for, and how do you know that an individual's choice has been what's measured and what's happened. So when we look at the numbers a bit more closely, we wonder, who was it who started on the same day? Was it the people who wanted to start on the same day? Who didn't start on the same day? Who didn't start at all? And that's where we really reap the benefit of the manual audit. So while some of us moan quite a lot about completing the audit because it takes a lot of time, it's really, really rich in information. And if there are clinical staff working in the services who are not participating in audits of the MAT standards, you really would emphasize that it's a really worthwhile thing to do. It's so information rich in looking at what's gone well, but also what could have been a bit better. So what we learned looking in March is that people who didn't start at all in OST really fell into 2 main groups. There were people who chose a different treatment pathway than OST, for example, abstinence treatment. And there were people who were referred into treatment rather than self-referring themselves, particularly people who were referred by their GPs, who then the service tried to get in contact with, tried to outreach, but couldn't get in contact with them, or by the time they did, the person didn't want treatment. So that's an area for us for service improvement. Of the people who didn't start the same day, they really fell into 3 main groups. There were people who were offered same-day treatment but chose not to start on the same day. There were people who requested OST treatment with buprenorphine but had just used heroin before they came to seek treatment. And there were people who came and first asked for treatment at 4 o'clock or after 4 o'clock in the afternoon. So my colleague Jennifer in the MAT2 webinar is going to talk a little bit about our response with treatment choice of buprenorphine for OST start, and how we're trying to do things like take advantage of the pharmacodynamics of weekly Buvidal injection to manage a better response to that. And I'll touch again on the late treatment presentation. So the MAT standards and the MIS team talk about the quality improvement. So there's looking and interpreting our numbers, but also really the importance of experiential information. In Glasgow, we're having some governance issues around our work gathering experiential information from people using the service, and we hope to sort that out soon. We have had some feedback from people with living and lived experience in our ADP groups, who very clearly give a picture of a lack of some work needed to standardize our response across the city. So one person describing what he felt was an excellent response to his request for treatment and a good offer of what was available, and pathway and process into treatment, and somebody else who voiced the same request and had a very different response and didn't find it very easy to access same-day OST treatment. We also have observations from staff who have seen people leaving the waiting room partway through their assessment process for OST start. I'll talk about that, a little bit about that as well. And the other people who are obviously able to get some really important experiential information from is our staff group. So while the staff say that they found it really, really rewarding to be able to be in a position to offer same-day OST treatment or very quick OST treatment for people, they really describe a challenge of balancing safe assessment and the time pressure of delivering same-day treatment. Sometimes they feel that tasks are quite rushed, and sometimes they experience a loss of the sort of holistic approach of that initial contact with somebody, and that they feel frustrated that they're less able to prioritize what's important to the individual. So somebody who's seeking OST treatment but also has issues with homelessness, and they're not in the same position that they have previously been in terms of resource to deal with that. And the other thing that staff raises, having to stay late sometimes to deliver treatment, and a question of the same day starts, or would treatment within 24 hours, would that have been a more achievable standard? So thinking again, having sort of thought about some of those things, where are we now in Glasgow? And I think, again, I do feel that things have gone really well, are going really well. Everything we have achieved has been within our current resource. It's been during a pandemic. It's been in the context of national nursing and medical shortages. And maybe now we feel just a little bit frustrated and stuck. We really want to move forward with improving the quality of what we're delivering. And we're quite aware from feedback that we do have that we need to work on patient-centeredness, and we need to support our staff. The MAT standards were published in May 2021. And our ADP funding letter came through at the end of June 2022, more than a year later and at the start of the summer holidays. So really struggling to implement that, make use of that resource. But we know that we're aiming for full implementation 6 months from now in April 2023. So this funding that has come will allow us to staff enhanced front door teams and strengthen our patient-centered pathway. What we really want to be able to offer is a choice, not just a choice of MAT2, what OST would you like, but when would you like it? Would you like treatment today? Would you like treatment tomorrow? Is there a day next week that you had in mind for treatment? We haven't managed the nuance of that dialogue most of the time. And also, what would you like your treatment start to look like? Would you prefer a one-stop shop where you're going to come down and we're going to offer you a whole range of harm reduction interventions, naloxone training, and a whole lot of information? Or is that too much for one appointment? Would you really like minimal interventions delivered, a start in OST, and for us to talk to you about all these things over our next contacts with you? And I think we also really want to look at how do we define that more nuanced pathway, and how do we measure it to make sure that we're meeting the individual's choice and preference. So I think that's probably all that I wanted to say today, except to really thank the colleagues that I work with in the service who spent some time sharing their thoughts with me, and I hope that I have adequately represented you. Thanks.
Thanks so much, Trina. That was an excellent first presentation that really sets the scene of what's going on in Glasgow, and obviously I'm sure is replicated across other parts of Scotland. We're now going to hear from Shelley Jones from West Lothian. Thanks, Shelley.
Hello, my name's Shelley. I'm part of the West Lothian Addictions team, and we have implemented MAT Standard 1 from April. So before we implemented the MAT standards, what we did was we got our third sector partnership around the table, as well as the NHS addictions team. So that included the NHS, West Lothian Drug and Alcohol Service, and CGL. We discussed how we were going to implement the MAT standards, what documentation was required, and what services we would offer. We came up with a one-stop assessment form agreed by all teams to cut the number of forms that would be required during the clinic. We discussed what areas was in the highest need and which were areas to implement the first clinics in within our locality. And we opened one clinic in April until we had staffing on board. So our target audience was people who obviously use opiate drugs, people who have previously disengaged from our service, and people who were deemed high risk and required to be retitrated. We won't take under 18s. People who are pregnant are straight into our consultant instead of the same day prescribing clinic. And people who have already been allocated a key worker and is already currently under a titration programme. We do not have a referral service. It's an open door clinic. Anyone can come along. If they're under the influence of alcohol or other drugs, they will be asked to attend once they are sober. So during our clinic, we have myself as an ANP, we have our band 6 Claire, we have our band 5 Shannon, and we also have a full-time wild ass worker who's attached to the clinic. When the patient walks through the door in our area, the wild ass worker will run through harm reduction, needle exchange, naloxone, bloodborne virus testing. They will then come into us and we will do a full medical assessment. We will do on-the-day toxicology, ECGs, venous puncture if they require other blood tests on top. We will do a cow's assessment. What else we do? We do the whole full past medical history, allergies. Then we run through what the patient actually wants, what they want as a medication offer. Once we've discussed it between us and we've agreed on a treatment process, we will confirm with the pharmacy to make sure they can supervise our prescriptions, and they'll be issued a pharmacy on that day. What medications we offer? We offer methadone and we offer short-acting buprenorphine as well as long-acting buprenorphine the following week. So when they reattend for review, they can convert the following week onto Buvidal. The patient's offered a follow-up appointment at a clinic near them, because there's now 4 per week. The patient will continue to see one of either myself, Claire, or Shannon for a follow-up, and we will stay with us for about 6 weeks. Once the 6 weeks and they're stable is up, they will then be transferred onto the local key worker for that area for ongoing care. If a patient does not attend an appointment that we've scheduled and they've agreed to, our local CGL worker, Change Go Live, and our local wild ass worker will send assertive outreach to their houses, to phone them, to wonder, just to follow that patient up to make sure they're safe and what's happened that they didn't come back. So our clinics are running 4 days a week at the moment. We're hoping to open up a 5th one in 2 weeks' time in a different area. So since April, we have had 122 people attend our clinics. We have started 94 people on opiate substitute therapy. The difference in those numbers is due to people who maybe have problems with alcohol, cocaine, and other substances have turned up to the clinic to access same-day prescribing. So they're not suitable, but they will still be offered a referral into therapeutic support services, harm reduction, needle exchange for if they're injecting cocaine or whatever substance they're using, they will still be given that option. We currently still have 8 to 9 people in treatment that we started from the 94, which has given us a retention rate of 94% since April. We've lost a couple of people to legal issues, or they've moved area and dropped out of treatment. So that seems really quick. So we think we're doing not bad at the implementation of MAT Standard 1. We're hoping to extend it, as we said, We have run into a couple of issues getting local pharmacies who are already full to capacity for supervision and trying to arrange other pharmacies that our patients can actually get to. But so far, so good.
Thanks so much, Shelley. Could I just ask you, just because we've got a bit of time, you mentioned the 94 folk on OST. How many of those were the same day prescriptions? Do you have that data as part of that as well?
All of them.
All of them. Wow.
All of them. We haven't had anyone that has been delayed through the ones that are not included in the 122 account for the ones that weren't started. We have started 94 people on OST.
And have you, I don't know, you can say that precisely, but if you look back a year previous, what were the figures like in comparison?
I don't know, because I only joined the team to specifically set up this clinic for the MAT standard, so I don't actually know. I know the waiting list for West Lothian was around about 3 weeks, so the waiting list wasn't too bad that it was going to impact horrendously when we opened the same day prescribing clinics.
Yeah. Okay. No, that's great. Thanks for that, Shelley. That was really helpful. We'll now move on to our third speaker, who's Jamie Tidder from the Borders Addiction Service. Thanks, Jamie.
Thanks, Dave, and thank you to the SDF for inviting me to speak today. I'm going to use a few slides, mainly, hopefully, just to remind myself of what I was planning to say, but I might not stick to them precisely. And the other thing that I'm going to do today that is perhaps slightly different is that I'm not going to speak so much about the clinical challenges and the clinical decision-making in same-day prescribing, because I know other colleagues have already done that. I thought what I would probably do is speak a little bit more about some of the logistical and practical challenges that we've faced implementing MAT1 in a rural setting. So just to put things into context, for anyone who's not very familiar with the Scottish Borders, so we are a rural health board. We're obviously on the mainland at the bottom with the border of England, around 4,700 square kilometres and a population of about 115,000 people spread between 12 sort of significant towns and villages, and then a lot more sort of small little places just scattered all over the place. Our service is structured with a single community addictions team, which covers the whole region. We have long travel distances, but I should put that into context. It would probably take about an hour to an hour and a half to drive from our main base to most of the other borders population centres. That probably in terms of a patient needing to travel on a bus could be 3 hours or more. And obviously that poses real difficulties for patients if they're not in somewhere on the same day when they're seeking to access services. It also means from the point of view of staff that we have multiple satellite clinics across different areas in the borders, and arranging sort of the logistics of that is also complicated. So changes to our services. So in keeping with most other areas, by late 2019, there was obviously the recognition of increasing drug deaths across Scotland, and our service took the decision to change at that point prior to the MAT standards. So by the end of 2019, we'd moved to a same-day prescribing model as part of the low threshold assessment approach. We'd thought about how to try and lower barriers of access to services. We'd launched drop-ins with Prescribing available, and we'd launched our Assertive Outreach team. And we'd also moved to try and increase the choice of models available to people, particularly moving towards the introduction of long-acting injectable buprenorphine in April of 2020. So same-day prescribing obviously is what I'm been asked to talk about specifically today. And I suppose the first thing to think about is how do you actually define same-day prescribing, and how do you make that work and think about that in a rural service? The definition in the MAT standard is around someone accessing a prescription on the day that they request treatment. And I suppose that in a rural context is very, very difficult to achieve, particularly because someone might be phoning our service to self-refer from iMouth, at 4 o'clock, on Monday afternoon, and there is no practical way of us getting them to Galashiels, or even slotting them into a clinic in iMouth if we had one running. So I think the first thing that we have sort of accepted is that really for us, same day prescribing is about, and I loved the way that the chap said it in the video we had at the beginning, it's about when you go to a building, when you see staff members from an addiction service, there is that ability to prescribe for you, and you know that if it's safe and appropriate, you will be prescribed for on that day. And that is what our service has really aspired to do, to move to a model where the first time that someone is coming to see us, or we might be going to see them, we can have face-to-face contact, the ability to prescribe. I've added a comment in there about assertive outreach, just because we do sometimes, particularly after near fatal overdoses or people who are very risky, the team goes out, knocks on people's doors, and it may be that at that initial face-to-face contact, prescribing isn't possible, although there have been occasions where we've done it in people's homes. So we do sometimes try and do that. But generally speaking, it's about people having the knowledge that if we've invited you and you're coming to an appointment to see a staff member, there will be the option to prescribe for you on that day. So in terms of actually accessing them prescribing, so what settings realistically can we do this in? So we have the traditional clinic setting, we have drop-in settings, and we now have a drop-in for each of our major towns, and we have each major town has a drop-in once weekly, and most days of the working week there will be a drop-in running somewhere in the borders. But of course, from your point of view as a patient, you know, the eye-mouth drop-in is once a week, and if the drop-in's in Galashiels, you know, that's 2+ hours on a bus. So whether or not you're able to make that journey is a big challenge. The other thing, as I said, is we do home visits. We have prescribed at home visits. This is not particularly common. It's very resource intensive, and it can be difficult logistically to arrange. It can be difficult to risk assess, but our assertive outreach team has done that where it's appropriate. But generally speaking, it is still around people being able to attend a clinic setting or being able to attend a drop-in setting. So clinic settings, you know, we have to remember that for some patients, you know, they don't want to come to drop in. Some people will still very clearly say to us that they want the privacy, they want the ability to go to a clinic setting. And I think it's very important to respect those decisions that patients have. It might be easier logistically for us to just direct everyone to drop-ins where we're all set up to be able to do, you know, harm reduction interventions and naloxone training and prescribing, and staff are expecting that, and we've got staff planned and they're all there in the building. But actually that isn't always what patients want. Sometimes patients want, you know, to be able to go to clinic, to be able to see, you know, a member of staff on their own. This is really challenging logistically. In reality, we don't have clinics that run in every town in the borders every day of the week. When we do have clinics running, those clinics might be very heavily booked. It might not always be possible to squeeze someone in. And the other thing, of course, is that we may not have a prescriber available in that clinic on every day. And so how have we tried to kind of get around this? How have we tried to think about this? So the first thing has been adjusting the way that we do clinics, and that is really difficult. I know I'm speaking to an audience of people who work in very busy services, but trying to have staff with a little bit of flexibility within clinics, not having every clinic consistently overbooked, having actual, you know, time at the end where people are able, you know, to slot people in at short notice. It's very difficult to do, but it does allow us to offer short notice appointments with prescribing on the day. For some people, you know, who are able or who want to travel and want to be seen more quickly by coming particularly to our main base in Galashiels, we will offer them bus tokens. So if staff are passing through a town or assertive outreach are out and about, it's not uncommon that we'll ask them to pop to someone's house and put bus vouchers through the door. And in the same way, if someone is taking an expensive bus across to Galashiels to see us to be prescribed for when they arrive, we have bus tokens here and we would give them the bus vouchers they need to get back home again. And then their follow-up, we would try to arrange more locally by telephone and by local clinic follow-up. We also have a taxi fund, and certainly for people who we consider are very vulnerable or at very high risk or following overdose presentations, we do, you know, in contact with people over the phone, we do say, look, if we sent you a taxi, you know, here and now, would you be able to come across, you know, to Galashiels or to somewhere else where a prescriber is available to be seen? That is a fantastic thing to do. It is very expensive, and I think we have to recognise that, you know, I might love to just authorise that for everyone that asks for it, and I can't do that. You know, we don't have an unlimited pot, but we certainly do use that, and we're using that increasingly where people are struggling and are vulnerable. Assertive outreach, as I mentioned. So again, for people who are struggling to engage, having the team able to go to engage people initially at their own home or at a place in public where they feel safe, and then to actually have staff from Assertive Outreach drive them and support them to come to a prescribing appointment, or in some situations, either a prescriber has gone to their home or we've done remote prescribing electronically in people's homes, has allowed us to actually respond very quickly and to start those prescriptions very quickly. Remote prescribing I've put on here to remind myself. I will come back to it and some of the advantages and now the challenges with it. But that is another thing that we have done frequently, but sadly can't really do much anymore, is we've accepted that, you know, having a prescriber available in every town across a rural area is really difficult. But actually, do we need to do that? You know, what we found works very successfully is I can join on video call. There can be a nurse who's not a prescriber that's slotted someone into a clinic. They can do a COWS score. They can do a point of care urine test. They can do practical harm reduction advice, offer IEP, offer, you know, dry blood spot testing. And then I join as a prescriber. I participate in that appointment, and then I take the prescribing decision and generate a prescription from here. That did work very well for a while, and I'll talk about the challenges we're now having with that. So drop-in settings. So again, some patients really love the drop-ins. They're increasingly well attended, and they're not just about prescribing. They're about obviously building a community of people that support each other, allowing people to have more contact with services, and allowing other interventions as well as prescribing to be delivered, you know, when it's convenient for people and as people feel able to access them. But one of the things that they have allowed is prescribing. So we would generally always aim to have a prescriber at each drop-in session. This is not always possible, but it's something that we try very, very hard to do. For patients, it gives them flexibility within the drop-in window. They know that if they go, this is what will be available. They don't have to have had it pre-booked or pre-planned. And again, our service model now means that if we've never heard someone's name before and they arrive in a drop-in setting, they will be able to be assessed, and if appropriate and safe, they will be started on a prescription on that day. Again, challenges around this, we cannot resource and run a drop-in every day of the week in every town. So again, it's about thinking with the patient what suits you. You know, when a patient refers in and our staff do that initial telephone triage and have that conversation, what suits you? How can we get you what you're looking for and, you know, get you into treatment if that's what you want as quickly as you can? Do you want to wait a couple of days for the drop-in? Could we support you to travel tomorrow to a drop-in in a different town? Could we support you to travel to a clinic? It's about thinking with the patient what they want, but the drop-in is definitely very valuable. The practicalities of supporting prescribing in drop-ins, particularly because some of these are, in fact, many of these are not NHS premises. So we now have staff with laptops that remote in to our systems through 4G kind of little dongle things. We have portable printers that are set up to print prescriptions. We have all those kind of bagged up and staff can grab those and go out to the drop-in settings with them. Assertive Outreach, again, links into drop-ins. So sometimes if Assertive Outreach are working with someone, they'll arrange to take them to drop-in so they can access prescribing. And again, one of the things we've done is trying to have prescribers available in the central office who are not, again, completely booked. So if someone does arrive in a drop-in where there isn't a prescriber, we've been able to support that remotely, and that had been working very well. So it has not sort of escaped my sense of irony that in 2022 on a webinar, I've got a slide that is essentially talking about the problem of moving bits of physical paper from one town to another town. The challenge, as I'm sure many people will be familiar with, is that the Controlled Drugs Act is quite clear that a pharmacist should have the physical paper prescription in their hand to dispense OST. During COVID locally, because it was just so difficult and so risky and there were so many changes needed, we agreed with pharmacists that they would accept us scanning prescriptions from our central office, emailing those in high definition through the secure email system, and they would honour and act on those prescriptions on the day while the paper prescription came across them in the post. And it's this agreement that essentially allowed us in 2020 to start remote prescribing and to carry on with it up until the last few months. What has now happened is, quite understandably, pharmacy colleagues have turned around and said, actually, this isn't really supported by the legislation and this isn't really COVID anymore. So these, you know, emergency measures that we were happy with, we're not happy with anymore. And very frustratingly, this has essentially put almost a stop to us being able to do remote prescribing, because we now cannot practically get the paper prescription from one town to another town in a realistic timescale. It is something that I think we demonstrated can really work and worked very well. It's something I would love to see us going back to doing, but I think we're now at the point where we would need either a change in legislation or the government to rapidly roll out some kind of electronic prescribing system, and either of these are not easy asks and obviously are very difficult for them to do. But I think it is worth mentioning just because it was very successful. We had no sort of safety incidents or problems around it, and it definitely did allow us to support people to get into treatment quicker than it would have done otherwise. So just then to try and start summarizing and bringing some of these things together. So rural areas are all very different, and I'm talking about some of the issues that we faced here, and some of these are in common with other areas, but I'm also very conscious that we don't have things like ferries between islands. An hour and a half in a car actually is quite a short distance compared to some other parts of Scotland. So for some rural areas that the challenges are even bigger than they are here in terms of those distances and those geography. But the other challenges that the areas can face are around workforce, and we've been very, very lucky here that we actually have managed to recruit new staff, and we are relatively well staffed. But when you're in a rural area, it can be incredibly difficult to recruit staff, let alone experienced prescribers, and that is amazingly challenging. How do you organise and run services across large areas without the skilled staff that are needed? And how do you organise staff time to allow that one person who needs it in a far-flung place to be able to be prescribed for and started quickly without running a clinic that might not be heavily utilised 8 times out of 10? So very, very difficult decisions for services to make. I'm going to come back and mention patient preference again, because I think it is so important. Same day prescribing and a target of you have MAT on the day that you request it is brilliant. But actually, for some patients, the only way I can offer you that is saying to you, fine, get on a bus and travel for 3 hours and I'll see you today. And for some people, actually, they're not able to do that. It's not practical for them to do that. So the approach we take very much is trying to say to the patient, look, here is the range of options we can offer you. How do we work with you, to try and get something, rapidly, but that also actually is something that is what you want, what's appropriate for you. And lastly, just to mention just the sustainability of some of the solutions that we've come up with and that we've been using. I've already talked about remote prescribing as being something that was really, really positive, but that has now come to an end. And we are now, of course, finding it, harder, to offer things as quickly, because we're now having to physically either move prescribers or move patients. There are costs to some of these interventions. Taxis across the Scottish borders are not cheap. Assertive Outreach, is a new team, which has required new members of staff. And again, there is a cost associated with that. And I think it is just really important that we recognise that the MAT standards, great as they are, there is additional cost associated with doing them well. And we have to be very conscious of how we sustain that in the future. I would absolutely hate to see that in a few years' time, the funding tap is turned off and services that are really good, working really well, and have been, a lot of time and effort has gone into developing, then start reverting back to traditional models because they simply can't sustain what they're doing. And then the last thing I had on my list was which I think I've kind of covered already, is just that pragmatism about, services and MAT1 may actually have to look slightly different in different areas. In places like, Aberdeen City or Glasgow or Edinburgh, in a much smaller location with much better public transport, someone phoning in the morning and being able to say, yep, hop on a bus 20 minutes across to the city centre, come to our central prescribing clinic, which we run every working day, is a brilliant solution. But in a rural area, we cannot deliver that, and we can't organise things in that way. So I think it's also just recognising that, MAT1 here is about trying to allow people to know that when they see us, there will be the option of prescribing, but also working with them to say, well, how is it, what works for you to actually see us, rather than just saying, this is the only option we can offer you, get on a bus for 3 hours. So hopefully that has been useful. I'm very happy in the questions to talk more about the clinical bits and the decision making and the practicalities of how we do MAT1, but just to say thank you very much for letting me speak.
That's great. Thanks, Jamie. That's a really important coverage of all the issues, particularly in a more rural area like the borders. I loved your phrase, not really supported by the legislation. That was a master of the understatement, I guess, there, but thanks for that. I wonder if I could maybe just kick off. I thought, obviously, I'm quite familiar with the borders and the model, and you mentioned, Jamie, if you want to, thanks, Shelley. As you mentioned, that the drop-in centres versus sort of clinic appointments, etc. And I wondered, whether the two other areas have looked at that in terms of the balance of provision, which I think is exactly right. Is that obviously that's not for everybody, and we need to be person-centred. Trina, do you have thoughts on the sort of drop-in centre versus appointments models of care?
Yeah, sure. So I think because we're quite a big service, getting our head around what we should be offering is proving a bit of a headache. We have the opportunity at the moment because the NHS is finally sort of the words post-pandemic don't resonate with me because I'm just recovering from my first go of COVID. But we're finally getting some space in more buildings, but it is. Ideally, we'd like to offer a full mixture of, home visits, outreach, contacts in other places, some clinic appointments. And while we have drop-in availability all day long in our bases for new contacts, we don't run a drop-in model, particularly in most of the teams for people who are already in contact with the service. And it's something that I think would be useful. But how do you match what the individual person would like with how much of each you can offer? And we certainly don't want to return to the big clinics that we used to run. However, they're incredibly efficient. So nobody really likes them, and they wouldn't necessarily say they're best quality in terms of how tight, the time you have for contact and intervention, but they're very efficient from a service point of view. So that's exactly where we are at the moment in Glasgow, is the headache of what should we offer and how much of everything we should offer and how do we resource it.
Thanks. Shelley.
We found the clinic times was a barrier to some of our patients because they were finding it quite difficult to keep their time to come. So having an open door policy just meant that they could arrive, as long as they arrived before the clinic finished, they could arrive at any time. So if their bus was late or they've slept in, it was okay. It's the same when they come back for review. I always say to them, come back between 9 and 12. So it just gives them more flexibility because their lifestyle is very chaotic. We find open door is better than timed appointments, I think.
Yeah, okay, thanks. Can I bring Austin in now? Austin.
Yes, hi. We had a sound problem earlier on. Hopefully people can hear me. One of the questions was about a role, and this is seen as a kind of challenge to the NHS specifically, and certainly for statutory sector, but is there a role for the third sector, the voluntary sector, and what would that be in terms of specifically on MAP1 implementation?
Yeah, thanks, Austin. Maybe go to Jamie first, and I'm also familiar with the the borders discussions around co-location, so you might want to add that to your answer, Jamie.
Yeah, so I'm hoping that I've grasped the question correctly, Austin. So the question essentially is what part of this is the NHS and what part of this is third sector? Yeah, so I think that's a really good question. And I think that certainly in the borders, one of the things that we are really struggling with is to utilise the fantastic skill set and ability of our third sector partner. And the reason for that here is logistical. It's because we're not co-located in the same building. What we do have is we have our drop-ins, which are completely shared between NHS and third sector. So both NHS staff and third sector staff are present at those, and we are able to utilise the skill set in those settings, much more. The prescribing here obviously is, done through the NHS. What I suppose I certainly wonder about, and I suppose I'm diverging slightly, Dave, from just opiates, but one of the things that I'm very conscious of is the amount of people struggling with benzodiazepines. And while we focused very heavily on OST and OST prescribing on the same day, we have frustratingly held back from thinking about more benzo prescribing interventions. And for me, really part of that is the resource. It's that we're doing so much with opiates, we couldn't resource it. I wonder a lot about if we could see third sector partners involved more in key working and supporting benzodiazepine detoxes and utilising, because they are already doing the preparatory work and the diaries and the reduction plans. And if we could bring them in to support actually prescribing, I think that would be a wonderful thing, but we're not quite there yet. I have a feeling I've not answered the question, Austin. Have I answered the question?
I would say you have. Yes, Austin, do you want to come back on that?
No, not at all. No.
No.
I mean, I suppose the question, you know, in the longer term is, do we commission third sector services, and is there a role that, you know, isn't presently fulfilled? I mean, I know around the previous policies, there was in some areas there was a third sector triage service in effect, or people were spent time doing pre-treatment work. And if that's to disappear or to shrink, you know, what might replace it?
So I suppose the challenge with having third sector kind of at the front door, so to speak, and doing the assessments, is it's making sure that doesn't then become a delay, you know, a barrier to then accessing prescribing, which is through the NHS, or in the very worst case scenario, actually, to be honest, just a hidden waiting list where people are held in third sector, not referred to the NHS. And then we also look at our beautiful stats where we're meeting these wonderful waiting time targets. So I suppose our model here actually is that we have essentially abandoned that. So we've said that if someone phones and self-refers to third sector because there is no wrong door, but says what I'm struggling is with opiate use, that referral is instantly passed across to the NHS, and actually it would be our team then that would reach out to that patient, assess triage, and then arrange access into prescribing if appropriate. And that is to avoid delays. It doesn't mean that person wouldn't then be offered the opportunity to work with third sector as part of their ongoing care and follow-up. It just means that the NHS has taken that responsibility for, if at the very beginning we're identifying there is likely to be a prescribing need, there is no delay. We just try and do that as quickly as possible. And for me, that's what the sort of the low threshold model it really is. It's about saying we do the minimum to allow you to access a prescription. We hope that having you in treatment and on that prescription then makes it easier for you to complete that comprehensive assessment around your physical health, your mental health, your social needs. It's not in any way devaluing or removing that traditional assessment. It's actually saying, hopefully we can do this better and we can engage you better because we've met your prescribing need right up front.
Yeah, and that's an important point, and I think that that has been the case in the past, that the 3-week waiting time in some areas has been the third sector has been used to meet that in a way that, as you say, potentially just adds a further waiting time. Shelley, do you want to come in there, because you talked quite a bit about your work with the third sector as well?
I would like to think we have a wonderful working relationship with our third sector partners. They're in attendance at every clinic that we run for same-day prescribing. They will see if people come out for opiate substitutes therapy, they will also see anybody and direct them straight in to the third sector if they're not suitable for opiate substitutes. So I feel that we've got a very good co-joined working relationship that stops putting barriers up for our patients.
Thanks, Shelley. Trina?
I don't have a huge amount to add. We've got some very strong relationships with third sector services in Glasgow, who do a variety of roles really well. I think where it comes to our attention is, in a particular to answer the question about supporting in particular MAT1 and access to services, where I've seen it be helpful is where there maybe isn't that standard response that we're aiming for in a specific instance, and supporting the particular individual to say, do you know the MAT standards, this is what you should be expecting, and supporting to get a slightly different response from the service. So, certainly I think that's been very useful when that's happened for us.
That leads us on to the next question, Trina, which is about communication with people who use or might use services. So we're offering as a treatment to a community of people who use drugs, who have quite set views about what treatment involves and what the experience is likely to be like through their own experience or the experience of others. So how do we communicate with people that things are changing, if not they've changed wholly and radically? How do we get that news out there, and how do we encourage people to be more trusting of services, or the ability of services to change, maybe is the question.
Well, so I think there's a couple of parts of that. There's no point in communicating until you're actually able to deliver a good quality service. So the last thing you want to do is communicate to people, come and get this service from us, and then actually what's experienced is still, you know, some historical version of a service. So the very first thing is making sure that we have our resource available and are doing our quality improvement work. In my experience, the most powerful thing has been listening to the voice of people who've accessed the service and the staff who are delivering the service. So I think those are the voices that we really need to get out to the communities, and I'm not sure that I'm the best person to answer how that voice would get out there. I would have thought people who've accessed the service might be better to give an opinion of how that message would get out.
Thanks, Trina. Yeah, I mean, I think it really is challenging to change the perceptions of the folk in need of the service, because those can, you know, a bit like you know, the new Hep C treatments, or not that new now, but still, you know, people still are thinking about the older treatments or don't have the full awareness, and obviously the awareness of the MAT standards themselves. Shelley, I mean, obviously your service in terms of the same day stuff can change rapidly over a short period of time. How do you think that message has got out to those potentially in need of your service?
We did a lot of word of mouth work with the local GP surgeries. We put up posters. We had third sector. We've had patients bring along their friends to the drop-in clinics. So advertising we found very expensive, to be honest. We did look at radio advertising, but it was just too much money. So it was all posters and word of mouth.
And that worked?
Yes, so far.
Yeah, very good. Austin, is there another line of questioning?
I suppose the other question is about staff reactions, and the two issues that we've covered previously and spoken about have been staff burnout and the difficulty in recruiting staff. And is MAT implementation differentiate between the short and the medium term, but has it impacted in either of those things in terms of burnout or people's motivation to work in services?
Yes, I think we are very fortunate here that, you know, Addictions in the Borders is still seen as a good team and a team that people want to work in, and we're lucky that when we've advertised posts, we've usually had multiple applicants. What I think Austin's, you know, is asking about, particularly about burnout, though, is definitely something that I am very, very conscious of and that we have seen. And there have been points actually where I've had, you know, nursing staff very, very stressed because they're saying, you know, this person needs to be started and I'm struggling to find somewhere to slot them in, and they don't want to go to a drop-in, and what do I do? And there are points where I've had to say to nursing staff, you know, just, you need to take a step back. You know, we can only do what we can do. You know, we aspire to offer a good service. You know, we can offer a range of options to the patient and we work with them to choose the best one. But if we can't offer them an option to come in the next day or the next couple of days because we just don't have it, you know, we mustn't let staff take that pressure onto themselves and feel that they are under this, you know, it's all down to me as this person's nurse to rush around and try and arrange something. And that has been something we've had to really carefully manage, because the MAT standards have been great and the changes to the team have been great in lots of ways, and it's been really positive to do things so quickly, but it has left sometimes staff feeling stressed and under pressure that we have to respond to everything instantly when we just can't practically do it.
Thanks. Shelley?
Again, the same as James, we're a relatively large team, so we were very lucky to get funding to bring on myself, my band 6, my band 5 as an additional resource into the team. So it wasn't putting extra pressure on the existing team that was there. We also managed to get funding for a full-time admin member, which has been, it's been a godsend, really. So we've been very lucky that the additional funding meant we could bring in additional staff to take the pressure off the existing key workers, which I think's worked well.
So you haven't had significant experience of burnout?
I think we have previously, you know, with the waiting times and short staff, like everywhere, COVID, you know, trying to meet targets. But I think it's starting to get better now because we have got more staff in place now, which has made things a bit easier.
Thanks. Trina?
And yeah, I think I touched on this a little bit when I was talking, but yes, we're definitely experiencing staff burnout and stress. It's difficult to tease out, is that in response to the MAT standards? Because, you know, as people have said, some aspects of the implementation are positive. We've also got the impact of the pandemic and, you know, various other things, our substance use treatment target and everything together. So it's difficult to say that, but yes, I think the MAT standards has contributed to a feeling of stress and pressure, and you know, we're concerned about staff about that, and really looking forward to putting, you know, changing this funding into increased staffing resource, looking at bits of work that if we're not unable to recruit the amount of nurses that we would like to recruit to the city, what other professional roles can we develop or expand as alternatives and things like that. But yes, I think it's a really concerning issue.
Thanks. I wonder, you know, given the three of you have talked, you know, about progressive changes to the service. Obviously, there are parts of Scotland that haven't moved as quickly as yourselves. What's, I mean, you know, I suppose the question is, what would you be your advice to those areas, both in terms of, you know, support from a strategic level, but also how to support the staff in buying into the proposed, you know, to the changes that are required. Trina, do you want to go first on that one?
It's quite tricky to answer. I think it's a very clinical aspect of service delivery, and so you do really need strong clinical leadership, I think, as well as a whole variety of other things. And I suppose what I would say is what I mentioned a bit about, you know, the senior clinical staff in the area looking at what is actually happening to people from the moment that they request OST, and reading that patient journey and record and looking at the points. It's very, very strong, and you very quickly identify sort of issues, barriers, and potential areas for improvement. So that would be my recommendation in areas to try and get senior clinical staff involved in the actual audit information.
Thanks, Trina. James.
So I think it's a really big and complex question, Dave. But if I tried to give the two headlines, I suppose I would think of it in terms of two areas. So the first would be, you know, the clinical area and clinical practice and clinical decision making, and then the second would be kind of, you know, process and policy and logistics. So in terms of the clinical bit, it is and it was a very big change in practice to move from a traditional assessment model where, you know, someone's had a couple of lab toxes, you know, someone's attended several appointments and you've got all the background history, to an appointment where you're saying to prescribers, we'd like you to make that prescribing decision on the first day you see someone, and then do that assessment afterwards. And that is something that is a big shift. Once people get used to it, actually, I think it is quite straightforward, and it is certainly possible, and is what we're doing. But what I found, it was helpful. So the first person in the service that did that was me. So I was the first person that said at the start, when we began to trial these changes, you know, as the senior clinician, I will see them. You know, I will then let other people from the team shadow those assessments with me and see how I'm doing them. I will then free up more of my time. So as other people start doing those assessments on their own, they know that I'm available and they can phone me and discuss those patients and be happy with what they're doing. And then as our senior NMPs have become more and more confident, it has just become completely established practice. But it's about allowing people to make that change, to feel led in that change, exactly as Trina says, with senior people taking those risks. And sometimes it is more risk. You know, we are prescribing for people who historically we would have sent away. So people who are, not in withdrawal, and we're giving them buprenorphine to take away to self-titrate. You know, people who we've seen a couple of times and we only ever see them intoxicated with Assertive Outreach, and we're starting them on tiny, 10 milligrams of methadone and titrating from there. You know, these are folk who previously we'd have said, no, just come back when you're in withdrawal. And it is a different level of risk, and it does need senior people to take those risks and to support other staff to feel comfortable with that clinical practice. And then the second thing that supports that, I suppose, is the policy and the protocol. So making sure that your service then updates your prescribing guidelines so that the organisation is carrying that risk with with your staff. So if I'm asking people, and saying, this is what we're now going to do, have I got very, very conservative and safe guidelines that staff members can follow and know that their defence will be with the organisation if they're following that practice? And then the last bit then is the logistics, and that actually has been the hardest bit, is how do you organise it? How do you maintain it? How do you not burn people out? How do you practically get bits of paper from one town to another bit of town? Those are the bits that really need to be thought through, and that sometimes are very, very difficult.
That's great. I'm sure that those were really, really helpful answers for the audience. Shelley, do you have anything to add to that? I know you're quite new into your service, so a slightly different perspective maybe.
To be fair, I would echo what James is saying. We're very experienced clinical senior staff members, and we have good medical support here. So it's about bringing our, not so much junior, but staff with not a lot of confidence into the clinics to see what we're actually doing. And it's not magic. It's actually just, it's a process. It's just a process.
Thanks. Austin, back to yourself. We've still got...
Yeah, there's a couple of questions, but just to say there's a few questions come in that are really about other MAT standards, because of course all these things are linked about optimization and choice of treatment and so on, and I'll take note of them and ask them in future webinars. But a couple of things which I suppose if people beginning to think about, could this all go wrong? And the two questions are, what do you do with somebody who is an intravenous user of cocaine as well as heroin? And is that changed by same-day prescribing? And the other thing is about people who take advantage of the fact that services are easier to access and access and get an appointment once, and then the follow-up's difficult with them. So what happens about in terms of getting them into an optimal dose and so on if you don't have any more follow-up with them? And then how do you keep that person in treatment, which obviously is another MAT standard you're trying to comply with?
Sorry, Trina, but I'll come to you first, I think, with the cocaine and opiates.
Yeah, so in Glasgow City, the use of intravenous cocaine has overtaken the use of intravenous heroin. It's not an unusual scenario for us to have somebody who's using both. And we would absolutely still aim to get that person into treatment that day if that's what they would like, and deliver as much harm reduction intervention and things that we can at that time. So there wouldn't be any difference in our approach to that individual. We would just, as usual, try to encourage them to titrate up to an optimal treatment dose as quickly as possible, and so that we can try and start to get some psychosocial interventions around their intravenous cocaine use.
Thanks. We stick with that question first, and Shelley, what's your experience in that regard?
So we have had a couple of people who have accessed the clinic and then fell out of treatment and came back again about 6 weeks later and accessed again, but quickly fell out of treatment again. And it turned out they were actually in a different ADP locality, and they had temporarily registered at the GP in our locality in order to access the clinic. Unfortunately, we couldn't send our Assertive Outreach or our third sector partnership to do outreach work with them because they are in a different locality. They haven't came back yet, and we're not able to reach them. But if they come back a third time, I think we'll probably do more in-depth assessment before we commence them back on a same-day prescription. So we have had a couple that have just not worked out for us. So it is a big barrier.
Yeah, but as you described, in terms of those numbers that you described, you had very high retention rates within those same-day prescribing.
As I said, we will offer them. They don't have to come back to the clinic and the first attendee. They can come back to any of our same-day prescribing clinics over the course of the week, just whatever is easiest for them. And we give them between 9 and 12 or 1 and 4. It's not a set time.
Thanks. Jamie.
Yeah, Simon, I think we're fortunate in the borders. I think our rates of IV cocaine are probably lower than Glasgow, but we do see it here as well. And just like Trina, we would be exactly the same. So it is about accepting that, you know, services need to be willing to take more risk and carry more risk, and that actually being very defensive and sending people away because they are, you know, slightly intoxicated, or, you know, they have told you that they've just used a whole load of cocaine, you know, an hour before they've come to see you. They've come to see you, you know, they are there with you. And if you don't, you know, exactly, again, Dave, as the guys were saying in the video you played at the beginning, you know, for some folk there is a window that we have where people feel in a position and they're there in front of you. And sometimes my experience is that even if you do need to be very, very conservative, you know, even saying to someone, you know, we'll give you 10 milligrams of methadone and we'll increase it tomorrow, you know, and we'll see you again in 2 days. And even just getting the ball rolling, allowing people to feel that, you know, we want you, you know, we want you to be in treatment, we want to engage with you, has allowed us to bring people into treatment who I just don't think would have engaged with the previous model. Not sure they'd have come back if we'd have said you're really intoxicated, go home. I think one thing we do have to recognize, though, is that certainly what we've seen in our service, and we are a very small team, is after we've changed to this model, you know, we've had a big jump in the number of people we've retained in treatment. But actually in that cohort, we have very chaotic people who I just don't think would have been with our service before. And actually they take a lot more input and key worker time and chasing, and they need more, you know. And the reason they weren't in our services before is that we weren't offering what, you know, that stuff, weren't offering what they needed. But it takes a lot, you know, it takes an awful lot. And we've certainly seen folk who are sitting with Assertive Outreach for a lot longer than I originally thought they would, because actually they need so much. And that's brilliant, and that's what we should be doing. But again, it's about thinking about, how do you do this sustainably? How do you resource this? How do you not have staff burning out? You know, and how do you actually, you know, create a service, you know, that isn't just going to be rolled back in a few years? That I think is the really big challenge.
Thanks, Jamie. Trina, you were nodding there. Do you want to add anything to that?
No, I don't really think I've got. It was just really the amount of staff time and input that outreach and follow up is taking up is, yeah, our frustration with sort of needing increased resource to be able to do this well. And I guess, you know, what we haven't really spoken about is the impact on other parts of our service. So while it's fantastic to be able to offer same-day treatment and to outreach follow-up people for their titration appointments where necessary, then, you know, we're still doing that in our unenhanced resource. So there has been an impact on our ability to focus on our delivery of alcohol care and treatment and our delivery of routine care and reviews to people who are in maintenance OST treatment.
Thanks. Yeah. Austin, is there one more question?
Well, the only other question I think that's relevant, just because it came up, is about paper prescriptions, and you'll be aware of the ministerial directive to local service commissioners and planners. So is that part of the response that locally they should ask that paper prescribing can continue, or is actually the resistance to it local rather than just the legislative problem?
Jamie, do you want to, because that was your issue.
Yeah, absolutely. So I mentioned this when Angela Constance came to meet with us in the borders, and her team went away and looked at it and came back with the answer that I expected, which is, so I thought, you know, this legislation is reserved to Westminster. So it's not as simple as me just saying the Scottish government should change it. Actually, Westminster is responsible for the Controlled Drugs Act. I will absolutely not criticise pharmacy colleagues who do not feel comfortable doing what I've asked them to do. It is, you know, as you say, Dave, I'm being very, conservative in saying it's not in keeping with the legislation. It's outside of the legislation. You know, that's what we're asking them to do. We are immensely grateful here for pharmacy colleagues that agreed to do all this through COVID and to keep it going as long as they did. I think it's been very helpful because it's demonstrated that it can work and it can be done safely. And even frankly, just with scanning the bits of paper that we have at the moment and sending them securely through an email system, we have not had a single issue with this. In fact, we had some pharmacists who said, we preferred this because your patients lose these scripts and then we have to chase you to get them to send new ones. So we had pharmacists when we were doing this who said, I know they're physically with you in your building, but do not give them the script, scan it to us and post it, and then we'll have it. But I equally completely understand why they're now saying we cannot keep doing this. This is not within the legislation. I think that they're within their rights to do that. ultimately, as I say, the only two things that will allow this would be either a change of legislation in Westminster to say that you don't have to have the physical paper prescription and a scan or something like that would be appropriate, as I believe they do in Ireland. And as far as I know, it's within their legislation. Or alternatively, systems like I know in England, you know, the GPs send prescriptions electronically to community pharmacies, and that is, again, completely legal and valid for CD prescriptions because the prescription is an electronic prescription, not a paper one that's being scanned. One of those two things, I think, is what needs to happen.
Okay, so thanks very much. We have, I think, 3 minutes left. So maybe if I just ask the panelists for their final thoughts on MAT Standards 1 in very succinctly. Shelley, do you have any final thoughts?
I think it's been a very good thing that the Scottish Government came out with MAT Standards. We were doing something, but it wasn't working, and we need to try something new, and we need to try something innovative. And I think this is the way to do it. People shouldn't have to wait to get treatment.
Thanks, Shelley. Trina.
Yeah, so like Shelley, I agree. So MAT Standard 1, same day access to actual prescribed treatment absolutely should be available to people, and I totally support it and think it's a really important thing that's being put as a national standard. I do think that we need to make sure we don't lose the nuance that it's the person's choice. So we should be able to offer it. We need to be really careful that we make things patient-centered and not service-centered, and we don't try and just put as many people as possible on OST on the same day, whether that's what they actually wanted or not.
Thanks, Trina. Jamie, we'll give more or less the last word to yourself.
Thanks, Dave. I mean, I really agree with what my two colleagues have said, and especially what Trina said. I think it has to be safe and it has to be patient-centered. And I'm very glad that there was resistance to setting, you know, a target. As Trina says, what is the right number of people to start on the same day? The answer is it's the number that are safe to do so and who want to be started on the same day. And I think for me, that's what it's about. And that's why we've chosen to define it as we want patients to have the option to do that if it's safe and appropriate and what they want to do.
That's great. Thank you all. Sadly, we've come to the end of our time, but the webinar has been recorded, and as we said earlier, an edited version will be published on the SDF YouTube channel as soon as possible. We'll be sending out an evaluation shortly, and it will be very helpful if you could complete that. And also, as highlighted, this is the first of a series of webinars on MAT Standards implementation. The session on MAT Standards 2 will run at the same time next week. If you haven't yet booked for this and would like to do so, we'll put a link in the chat just now and certainly send it out with the evaluation. So finally, I'd like to thank you all for attending, and obviously a special thanks to today's presenters who were all terrific in terms of describing the progress that they've made and some of the challenges that they still face. So thank you all for that, and I say hopefully see you all again at the next webinar next week. Thanks again and goodbye.